So we've already talked about the different zones of the adrenal gland and the hormones that are produced in the endocrine anatomy section. And now we are going to explore in more detail how these hormones are actually made. This is a very important concept to be familiar with, but there are only a few key things that the boards will actually test you on. So we will first go over the general flow of this diagram. that I will show you soon, and I will point out the specific details to focus on afterwards. The adrenal gland is responsible for producing what are called steroid hormones, and these hormones are all synthesized from what molecule? Right, cortisol. If cortisol is just sitting in the adrenal cortex, it doesn't have any motivation to change. What it needs is an enzyme to catalyze this process, desmolase, and that enzyme must in turn be activated by an external signal. In this case, it is circulating ACTH. There is a clinical correlation here as well. Ketoconazole, an antifungal agent, can actually inhibit the enzyme desmolase. As you can see in the diagram, desmolase catalyzes the conversion of cholesterol into pregnenolone. Pregnenolone can then enter two pathways depending on what enzyme acts on it. Now, to be honest, the key points are not to memorize every precursor molecule and enzyme. Save that brain power for the biochemistry section. One way this material is often tested is what happens when you have a deficiency in one of these enzymes. There are three key enzymes that can be congenitally deficient or deficient at birth, and these lead to different forms of congenital adrenal hyperplasia. You might be wondering how these enzyme deficiencies cause adrenal hyperplasia. If you go back to the idea of a negative feedback, you'll recall that cortisol is a major inhibitor of ACTH release. But in the case of these enzyme deficiencies, cortisol is not around to provide negative feedback. As a result, ACTH will continue to act on the adrenal gland and stimulate not only the production of hormones but also cell division. This leads to hyperplasia. A key point here is that this is not hypertrophy. There are three enzymes you must know as causes of congenital adrenal hyperplasia. They are 17-alpha hydroxylase, 21-hydroxylase, and 11-beta hydroxylase. Let's work through what effects the absence of these hormones can have by going through the diagram first. Then I'll give you an easy mnemonic to remember them. The first enzyme deficiency we'll talk about is 17-alpha hydroxylase deficiency. This is an enzyme indicated by A in the diagram. Starting with pregnenolone, we see it cannot be converted into 17-hydroxypregnenolone, not shown in the diagram yet. So its only option is to form progesterone, which is shown here. Similarly, progesterone cannot be converted into 17-hydroxyprogesterone, also not shown in the diagram yet, so it flows down this pathway and eventually leads to production of aldosterone, shown here. Now what happens to the patient's blood pressure when aldosterone levels are increased? Yeah, it increases. So this patient would present with hypertension. Now hypertension may be fairly common among adults nowadays, but it is not expected in a newborn baby, so keep this in mind if you're presented with a child with hypertension. Additionally, what would you expect the sodium and potassium levels to be? Correct, you would have hypernatremia and hypokalemia. If you don't recall why this is the case, as discussed in the renal physiology lectures, aldosterone works to increase sodium reabsorption in the distal convoluted tubule. It is also important to consider what is not made. And looking at where the blocks are, we see that both cortisol and sex hormone, both testosterone and estradiol, levels will be low. Let's stop and think about what effect low sex hormone levels would have on the human body. For a male, DHT is necessary for the development of secondary sexual characteristics and the descent of testes during development. As a result, the male patient will have ambiguous external genitalia and male internal reproductive structures such as undescended testes. We will review the role of DHT in sexual development in a bit more detail a little later on. In female patients, the external genitalia and internal reproductive structures are normal, but low sex hormone levels prevent development of secondary sex characteristics when the child reaches puberty. Let's move on to the second form of CAH, 21-hydroxylase deficiency. This is actually the most common of the three forms of CAH. As you see from the diagram, if 21-hydroxylase were deficient, then progesterone would be blocked from being converted to 11-deoxycorticosterone. As a result, the hormone precursors get shunted over to form cortisol and sex hormones, and they do not make aldosterone. As a result, the patient will have what electrolyte abnormalities? You'd be right if you were thinking hyponatremia and hyperkalemia. These patients will be hypotensive too. You'll see in the notes that they mention that patients will have increased renin levels as well. How do you explain this? Well, because when you are hypovolemic, the kidney senses the decrease in blood volume and produces renin in order to eventually upregulate the synthesis of aldosterone. Increases in sex hormones, again testosterone and estradiol, leads to virilization in females, i.e. clitoromegaly, due to high levels of these hormones in utero. Lastly, we have 11-beta-hydroxylase. Similar to 21-hydroxylase deficiency, we see low levels of aldosterone and cortisol. However, an important difference between these two forms of CAH is that 11-deoxycorticosterone, shown here, has mineralocorticoid activity that is similar, though not equivalent, to aldosterone. So, therefore, excess levels of 11-deoxycorticosterone leads to hypertension, as opposed to the hypotension that we see in 21-hydroxylase deficiency. Now I'm going to show you a simple mnemonic to help you remember the difference between these disorders. Draw yourself a table where one column has blood pressure and the other one has sex, like this. Remember that blood pressure is going to be high in the settings where we have production of mineralocorticoids, whether that be aldosterone or 11-deoxycorticosterone. The sex column refers to production of sex hormones. Now, underneath each column, write the number associated with the enzyme, such as 17 or 17 for 17-alpha-hydroxylase deficiency. In this case, you have a 1 underneath BP and a 7 underneath sex. If we recall, these patients present with high blood pressure, but females are phenotypically normal. The 1 should remind you of an upward arrow, like this. This means increased, while any other number means no change. Try this out for other enzymes. With 21-hydroxylase deficiency, the blood pressure is normal, but sex hormones are increased, so we get virilization. So again, think of an arrow over the 1. Now with 11-beta-hydroxylase deficiency, both blood pressure and sex hormones are increased. And what is the molecule responsible for the high blood pressure? Right, 11-deoxycorticosterone, as I've shown in this table here. Next, I'm going to point out a few key molecules to remember. If you're presented with a patient who has increased levels of 11-deoxycorticosteroid, you should be thinking 11-beta-hydroxylase deficiency. The other important molecule to remember, and often is measured, is 17-hydroxyprogesterone. If these levels are elevated, you should be thinking of 21-beta-hydroxylase deficiency. Additionally, if 3-beta-hydroxysteroid dehydrogenase is absent, and that's this guy right here, DHEA levels will increase. Over on the right side, you'll see peripheral conversion of testosterone to estradiol, or DHT. Let's zoom in on this part for a bit. The relevant enzymes are absolutely critical for you to know because they are a target of several drugs, and this is how you're going to see them tested on the boards. Testosterone is converted to estradiol by aromatase, and aromatase inhibitors such as anastrozole are important drugs in the treatment of some types of estrogen-responsive breast cancer, i.e. those that express estrogen receptors. Testosterone is converted to DHT by the enzyme 5-alpha reductase. DHT will bind to androgen receptors with 100-fold greater affinity than testosterone. And as you'll learn about in your reproductive lectures, DHT stimulates the growth of the prostate gland. That is why inhibitors of 5-alpha reductase such as finasteride are used in the treatment of benign prostatic hyperplasia or BPH. Quiz time. Let's review what you've already learned about cortisol in our earlier lectures. Where is cortisol made, and what stimulates its production? Here are the answers. Cortisol is made in the adrenal gland, specifically the zona fasciculata, and ACTH stimulates its production. So let's talk a bit more about cortisol. Once it enters the bloodstream, it is going to be carried by corticosteroid binding globulin, also known as transcortin, which is produced by the liver like many other carrier proteins. Now, not only does our body make cortisol, but we often use it as a drug to treat various conditions. Think about the functions of cortisol as we discuss them, and this will help you remember the side effects glucocorticoids have on the body. Understanding these means less memorization for you in the pharmacology section. The first function of cortisol is to maintain blood pressure. Do you know the underlying mechanism for this? It does this by upregulating alpha-1 receptors in arterioles. As a result, it increases the vessel's sensitivity to circulating norepinephrine and epinephrine. This is an example of the permissive effect, which is a phenomenon that occurs when the presence of one hormone is required in order for another hormone to exert its full effects on a target cell. So in this way, cortisol, through its ability to upregulate alpha-1 receptors, increases vessel sensitivity to epinephrine and norepinephrine. Don't forget that it applies not only to endogenous cortisol but also exogenous cortisol-like medications, such as glucocorticoids. Cortisol can decrease bone formation, which is why patients who are on long-term corticosteroids are at increased risk for osteoporosis and will require vitamin D and calcium supplementation if taking glucocorticoids for more than 3 months. Additionally, since cortisol acts to increase gluconeogenesis, it can cause hyperglycemia, which over time may induce insulin resistance. In that way, it is considered diabetogenic. Do you recall another hormone that we talked about that is also diabetogenic? Growth hormone. Additionally, cortisol increases lipolysis and proteolysis, which counterregulate some of the effects of insulin. Another interesting effect that cortisol has is its ability to inhibit the function of fibroblasts. What do these cells do? Well, they produce collagen in the skin. As a result, long-term use of corticosteroids, whether it be topical or oral, causes thinning of the skin. Over time, this can lead to abdominal striae, as shown in the picture below. Don't forget this very common physical finding, which is often seen in Cushing's disease. Stay tuned for more on this in our pathology section. Next, let's discuss how cortisol acts as an anti-inflammatory or immunosuppressive agent. This is one of the most common indications glucocorticoids are prescribed. We are essentially trying to turn down the body's inflammatory response. Here, we go through the mechanisms through which cortisol decreases inflammation. It primarily works by inhibiting phospholipase A2, which leads to decreased production of both lipooxygenase and cyclooxygenase, or COX-1 and COX-2. These in turn decrease the production of leukotrienes and prostaglandins. This is a little fact that you may be tested on as it relates to both pharmacology and the mechanism of action of corticosteroids. Additionally, if you were to check a patient's CBC, do you know what population of white blood cells will be increased? Right, neutrophils. It does this in 2 ways. First, cortisol inhibits the adhesion of leukocytes. Something interesting about neutrophils is that normally, more than 50% of our total number of neutrophils are attached to the vascular endothelium, and this is known as marginalization. And they are ready and waiting for the right signals to respond to an infection. However, in the presence of corticosteroids, these cells aren't able to stick as well and become demarginalized and enter the circulating pool of blood cells. Additionally, glucocorticoids inhibit neutrophil apoptosis. In contrast, do you know what type of white blood cell will be decreased as a result of high levels of cortisol? If you guessed eosinophils and lymphocytes, you'd be right. And it does this by inducing apoptosis. Another effect of cortisol is that it inhibits histamine release from mast cells, known as degranulation. Lastly, cortisol will block IL-2 production. Do you remember what cells make IL-2? T cells. And what does it do? It stimulates the growth of cytotoxic, regulatory, and helper T cells. Perfect. If you didn't remember this, go back to the immunology lectures and review the cytokines in the cells that produce them.